is Carlos Ruggiero. Thank you for the invitation. It's my pleasure and honor to participate in this Congress. My topic today is imaging of pediatric core tumors. I have no disclosures regarding this presentation. Let's start with the symptoms. As you know, the symptoms of pediatric spinal tumors are highly non-specific. Pain is almost always the rule, and it is usually present at night. Sensory and motor symptoms are very frequently found: progressive scoliosis, progressive torticollis, and headaches, which is very interesting, and I'll show you a couple of cases with this presentation. The onset is crucial because in general they present with a chronic presentation, and an acute onset speaks very against this diagnosis. The clinical history might be relevant because the presence of other tumors inside or outside the central nervous system, the history of a recent infection or vaccination, which may lead to the diagnosis of an inflammatory process of the spinal cord, and the family history. Remember that there are several congenital syndromes that might be associated with these tumors. We have a short list here, and in the same vein, the presence of birthmark, both pigmentary or vascular, might be relevant. Okay, regarding the location of spinal tumors in general, 2/3 of cases are located in the extradural space and 1/3 in the intradural compartment, and specifically intramedullary tumors accounts for 25% of total spinal tumors, and most of them are of glial origin. Overall, 10% of all central nervous system tumors are located in the spinal cord. And regarding localization with MRI is very important, but sometimes it might be misleading. For example, in this case, we suspected that subpiral infiltration, but on axial, you can see that they are actually two nerve sheath tumor with an intradural, extradural extension. Let's talk about astrocytoma. They are the most frequent spinal cord tumors in pediatrics. They account for 60% of cases, and most of them are low-grade gliomas. We use the WHO classification, the last one, the 5th one, which was released last year, and they use the integrated and layered report structure with a first layer of histological diagnosis, then the grading, and finally the molecular information, which, as you know, has become more and more important. They usually occur in the first decade of life. Pilocytic astrocytoma in younger patients, especially in the first 5 years of age, and pediatric type diffuse low-grade glioma a bit later, around 10 years of age. In general, they have some mutation of a molecule of the MAP kinase pathway, specifically KIA BRAF fusion and BRAF V600 mutation are the most frequently found, and it's very important to detect these mutations because both of them have specific targeted treatments. Here you have a typical image of a pilocytic astrocytoma at the cervicomedullary junction, which is maybe the most frequent localization. The second most frequent is the cervicothoracic junction. In general, this tumor comprises less than 4 vertebral bodies. They have an eccentric growth, well-demarcated margins, and frequently we find cysts, as in this case, but there are around 40% of cases without cysts. The presence of edema is variable. They usually enhance with contrast with different patterns. You can see here a heterogeneous pattern in the solid portion and the enhancement of the walls of the cysts, but there are around 30% of cases without enhancement. And the outcome depends largely on the extension of the surgical resection. Here you have a diffuse astrocytoma, what we used to call a fibrillary astrocytomas. This was a 13-year-old girl with back pain, and we detected this tumor with well-demarcated, a small cyst in the middle of the tumor, but the tumor did not enhance. And I had the opportunity to follow this girl for a long time. And I can tell you that the outcome was excellent. It was a very indolent tumor, very benign. Unfortunately, we have to face occasionally these high-grade astrocytomas. They are uncommon, but now we know that most of them are diffuse midline gliomas because they have the histone 3 K27 alteration. They have an infiltrative growth, ill-defined margins, inhomogeneous enhancement. You can see here this appeal dissemination, and they are usually associated with CSF seeding, bleeding, and necrosis. You can see this relatively low signal intensity on T2 and restriction on diffusion, which speak about the presence of high cellular content. And speaking of the enhancement patterns, I would like to stress the importance of differentiate these two compartments. We have the subarachnoid compartment between the pia and the arachnoid, and the subpial compartment between the pia and the glia limitans. And tumoral cells can go from one to the other because of adhesion molecules that they have at the membrane of the cells. And on imaging, they are different. For example, in this case, we have this subarachnoid pattern of enhancement at the thecal sac, and here you have the typical subpial enhancement with the sheath layer of at the surface of the cord, and sometimes they are associated with these subpial nodules that protrude into the spinal cord. I would like to tell you, to show you this case because I had the opportunity to see this boy some years ago. It's an old case, but it was very didactic. It was a 10-year-old boy with chronic headache and papilledema. You can see here the empty sella, the protrusion of the heads of the optic nerves into the vitreous, and this tiny hyperintensity at the subarachnoid spaces of the posterior fossa that honestly I didn't detect at the beginning. It was interpreted as an idiopathic intracranial hypertension syndrome, but some months later, the patient complained of back pain. We performed a spinal MRI, and you can see here this expansile lesion at the thoracic spinal cord with ill-defined margins, very heterogeneous enhancement, some dissemination at the subpial and subarachnoid spaces. And on top of these, you can see this heterogeneous signal intensity from the vertebral bodies. We completed the study with CT, and you can see this metastatic osteoblastic metastasis of the spinal cord, of the spine, and you can confirm this with SPECT. Many years later, the pathologist could perform the PCR for H3 K27 mutation, and we could confirm the diagnosis of a diffuse midline glioma, and it was a fatal case. The second most frequent tumors in pediatrics at the level of the spinal cord are the glioneuronal tumors. They occur more frequently in the first 5 years of life. They account for around 15% of all intramedullary tumors. They are usually low grade, but occasionally they can malignicize or become malignant in the glial component. They have local recurrence. They are present at the cervical and thoracic segments, and sometimes they have an hollow cord pattern. Calcifications are very, very specific, even though they are not very frequently found. They have a solid and cystic components, and the enhancement and edema patterns are very variable. This is a typical case located at the cervicomedullary junction.
You can see this relatively low signal intensity on T2. This is very frequently associated with a V600 mutation of the BRAF. This extension into the dorsal aspect of the medulla is very interesting, and it's very typical of a benign tumor because the pyramidal decussation acts as a barrier, as a limit from the extension of this tumor. Here you have another case. It was a very interesting case because at the beginning we detect this hydrosyringomyelia, look at the CSF artifacts on T2, but the signal intensity at the cervical spine was very bad. So we performed another study and with GAD, and we detected this ganglioma. So the message here is we have to study the whole spine and the whole, I would say, central nervous system with GAD in the presence of hydrosyringomyelia. We have another tumor which was introduced in 2016, which is the glioneuronal tumor, the leptomeningeal, diffuse leptomeningeal glioneuronal tumor. It's more common in males between 4 and 6 years of age. It has slow growth pattern, leptomeningeal dissemination. Sometimes it is associated with a MAPK or RK pathway alteration. Sometimes it has the co-deletion of 1p19q, and very frequently it is associated with hydrocephalus. That's why in our environment in South America, we have to differentiate this from tuberculosis. One key and very interesting finding is the presence of these pseudocysts at the subpial level, which are hypointense on T1, hyperintense on T2. They usually do not enhance, and they are located in the surface of the spinal cord, in the posterior fossa, sometimes in the basal ganglia, and in the frontal-basal area. Okay, let's go to the ependymomas, which are very rare in children. When they are present, we have to suspect NF2. Remember that now ependymomas are divided according to their location. We have the supratentorial, the posterior fossa, and the spinal cord variants. And in the spinal cord, we can detect the typical MICN amplified ependymoma, the myxopapillary ependymoma, and the subependymoma, which in children is very, very rare. We don't speak more about anaplastic ependymoma. You can see here a typical ependymoma. As we said, they are related to NF2. In these cases, they are usually multiple and small, and they are associated with Merlin mutation in the chromosome 22. The localization is usually at the cervical level. They have a central epicenter, clear delimitation, expansile and slow growth, vivid enhancement pattern. The CAP sign, which is this linear signal intensity, low signal intensity on T2 gradient echo sequences because of hemosiderin. And the polar cyst, you can see one of these here at one of the poles of the tumor. When they have the MMIC amplification, they have an aggressive clinical behavior, and the outcome is related to the presence of dissemination, the MMIC mutation, and the surgery. It's interesting to note that the distribution of fluid in ependymomas can be very variable. The tumor has leaky vessels, so there's a lot of interstitial fluid, and this fluid is squeezed from the area of the tumor to the upper or lower poles in different patterns. For example, you can see here a typical tumoral cyst with enhancement of the walls of the cyst. Here you have hydrosyringomyelia at the lower pole of the tumor.
Here you have a polar non-tumoral cyst without enhancement. And here you have edema that goes up into the medulla with this typical bifurcation, one branch into the fourth ventricle and the other into the ventral aspect of the medulla. We also have the myxopapillary ependymoma. They represent around 30% of all spinal ependymomas. We usually find these tumors in the second decade of life. They are intradural extramedullary tumors, and the origin of them is the filum terminal. They have frequent extension into the neuroforamina, and there is a likelihood of recurrence and metastatic potential, and that's why now we consider them a grade 2 tumor. Here we have 2 examples of this lesion. It's expansile, it erodes and remodulate the walls of the canal, very avid enhancement pattern, and they are always localized at this level. You can see here the surgery of one of these tumors. The surgeons must be very careful. They have to gently dissect these coda equina roots that are surrounding the tumor. Okay, let's go now to 2 differentials of this entity. This was a 16-month-old female infant. She had this tumor at the lumbar spine. You can suspect of a myxopapillary tumor, but look at this extension into the epidural space is not frequent in these cases. So we suspected another entity, and it turned out to be Ewing sarcoma. And this was a 13-year-old girl with again another tumor at the same level, with some cyst in the interior with high signal intensity on T2. But on the coronal, we could detect the displacement of the filum terminal to the left, and this turned out to be a sporadic schwannoma, and the clue was the lateralization of the film. Well, now I would like to show you some very interesting but uncommon cases that we had the opportunity to see in our center. For example, these 2 tumors that we interpreted as ependymomas because they had the typical characteristics. Look at this, the cap sign, the avid enhancement pattern, the edema, but they turn out to be astroblastomas, MN1 altered. This type of tumors was introduced some years ago among other variants, and they were interpreted as high-grade neuroepithelial tumors, but in the last classification, they remained classified as astroblastomas. They are rare circumscribed astrocytic gliomas with mixed solid and pseudopapillary pattern and a distinct methylation profile. ATRT are occasionally seen in patients, in pediatric patients in the spine. You know that there are 3 variants, the supratentorial, the infratentorial, and the spinal cord. Most of the spinal cord ATRT are related to MYC alteration. And you can see this case with an intradural extramedullary infiltration of this tumor with this subarachnoid extension, and the outcome is bad. They are usually related to one of these mutations. This was a very interesting case because it was a 15-year-old boy with a giant congenital melanocytic nevi at the level of the forehead and eyebrows. And we detected these tumors in the spinal cord, in the spine, 2 lipomas, intradural lipomas, one at the cervicothoracic junction and the other at the lower end of the spinal cord. There was some arachnoid cyst, but what caught our attention was this expansile lesion at the conus hyperintense on T2 and relatively hyperintense on T1 with some enhancement. And we interpreted this as a potential melanoma. Because of these lesions, the patients also had congenital glaucoma. But some months later, we performed another study and the tumor grew very rapidly, and it was operated on, and the histopathological examination showed these fusocellular cells, fusiform cells, and they performed a lot of studies, biomolecular studies. They were all negative, so they end up performing the genetic study, which revealed these 3 alterations. One of them is the NRAS, which is typical of the neurocutaneous melanosis. And these 2 alterations are typical of some soft tissue sarcomas. So it was tough to classify this tumor, but we can say that it was a mesenchymal non-meningothelial tumor. Regarding hemangioblastomas, they are largely infrequent in children. They have slow growth. Most of them are intramedullary, but we have also extramedullary tumors. They have clear margin, rich vascular support, high enhancement, and sometimes the presence of cysts. Most of them are related to von Hippel-Lindau mutation. The mutation is present in the stromal cells, not in the vessels. And in the treatment is the surgical excision. You can see here the VHL protein, which is a molecule that acts on controlling the hypoxic induced factor. And this factor has to do with the VEGF production, which in the end leads to angiogenesis. In these cases of von Hippel-Lindau, we can find several hemangioblastomas. In this case, you can see one at the dorsal surface of the spinal cord and the other at the level of the choroid. This is another interesting and rare case of an epidermoid cyst located in the thoracic spinal cord. When we find an intramedullary epidermoid, which is very infrequent, most of them are extramedullary, they are usually congenital and they are usually located in the thoracic spinal cord, as in this case. And the most important finding is the restriction and diffusion because of the typical signal intensity that produced the desquamation and breakdown of keratin from the epithelial lining into the interior of the cyst. And finally, I would like to show you this case. This was an 8-year-old girl with these lytic lesions at the skull and the enlargement of the pituitary stalk. It was a case of Langerhans cell histiocytosis, but we found this small lesion at the level of the lower thoracic spinal cord. It was hyperintense on T2, a little bit expansile with very tiny enhancement, and it improved a lot after the treatment of the disorder. So we suspect that it represents the presence of histocytes at this level, which is very unusual. And finally, just one differential diagnosis. This was an 11-year-old girl with this ugly lesion, with an expansile lesion at the level of the cervical spinal cord, with heterogeneous enhancement, with heterogeneous signal on T2 with these bright spots. Neurosurgery, the neurosurgeons decided to perform a biopsy very rapidly, and they administered steroids. We performed a control, and you can see the improvement of the lesion, the resolution of the expansile, the expansion, and the biopsy showed these macrophages filled with myelin contents. And afterwards, they performed the study of this patient, and it was a case of NMOSD because she had antibodies against aquaporin 4. So to conclude, I would like to remark the importance of knowing the clinical history of the patient. In terms of diagnosis, try to be accurate, but do not exaggerate, because many of these tumors appeared with the same pattern. Look for things that really matter, as dissemination, hydrosyringomyelia versus tumor cyst, cranial complications as hydrocephalus and intracranial hypertension. Look for the treatment-related complications so that we didn't have time to speak about, and always consider the differentials. And with this, I would like to finish up, and thank you for the invitation.